Welcome to Crazy Nurse RN Hub, where learning becomes a tradition. Come, join me as we explore the multifaceted world of nursing. Hi there, student nurses. My name is Criselmer Ducanes, clinical instructor teaching critical care nursing. To begin with, let's define critical care nursing. According to the American Association of Critical Care Nurses, or AACN, critical care nursing is a specialty dealing with human response to life-threatening problems. This involves assessing life-threatening conditions, initiating appropriate interventions, and evaluating the outcomes of the interventions. What about critical care units? Critical care units, or CCU, also known as intensive care units or ICUs, are designed to meet the special needs of acutely and critically ill patients. In many hospitals, the concept of ICU care has expanded from delivering care in a standard unit to bringing ICU care to patients whenever they might be. For example, the electronic or vital ICU assists the bedside ICU team by monitoring the patient from a remote location. What about progressive care units, or PCU? It is also called as intermediate care units or step-down units. It provides a transition between the ICU and the general care unit or discharge. Generally, PCU or progressive care unit patients are at risk for serious complications, but their risk is lower than that of ICU patients. Examples of patients found in PCUs include those scheduled for interventional cardiac procedures, such as stent placement, or awaiting heart transplant, or receiving stable doses of vasoactive intravenous drugs, such as diltiazem, or being weaned from the prolonged mechanical ventilation. Some examples of monitoring capabilities in these units include continuous ECG, arterial BP, oxygen saturation, and end tidal carbon dioxide. The use of PCUs provides critical care nursing for an at-risk patient population in a more cost-effective environment. Next, let's discuss critical care nurse. A critical care nurse care for patients with acute and unstable physiologic problems as well as their caregivers. Critical care nurse has an in-depth knowledge of anatomy, physiology, pathophysiology, pharmacology, and advanced assessment skills, as well as the ability to use advanced biotechnology. As a critical care nurse, you perform frequent assessments to monitor trends or patterns in the patient's physiologic parameters, such as blood pressure or ECG. This allows you to rapidly recognize and manage complications while fostering healing and recovery. You must also provide psychological support to the patient and caregivers. To be effective, you must be able to communicate and collaborate with members of the multidisciplinary health team, such as physician, dietitian, social worker, respiratory therapist, occupational therapist. As a critical care nurse, you will face ethical dilemmas related to the care of your patients. Moral distress over perceived issues of delivering futile or non-beneficial care can lead to emotional exhaustion or burnout. Consequently, it is important that all members of the health team coexist in a healthy work environment. Specialization in critical care nursing requires formal education combined with a preceptored clinical rotation. Advanced practice critical care nurses currently have a graduate, master's, or doctoral degree. This role is still not prevalent in the Philippines. Nurses are employed in a variety of roles: patient and staff educators, consultants, administrators, researchers, or expert practitioner. Now let's proceed to critical care patient. According to American Association of Critical Care Nurses, critical care patient is defined as a critically ill patient as one who is at high risk for actual or potential life-threatening health problems and who requires intense and vigilant nursing care. A patient is generally admitted to the intensive care unit for one of three reasons. First, the patient may be physiologically unstable, requiring advanced and sophisticated clinical judgments by a critical care nurse and a physician. Second, the patient may be at risk for serious complications and require frequent assessments and often invasive interventions. And lastly, the patient may require intensive and complicated nursing support related to the use of intravenous polypharmacy, such as sedation, thrombolytics, drugs requiring titration, and advanced biotechnology, such as mechanical ventilation, intracranial pressure monitoring, continuous renal replacement therapy, and hemodynamic monitoring. Now let's proceed to the common problems of critical care patients. The patient admitted to the ICU is at risk for numerous complications and special problems. Critically ill patients are usually immobile and at high risk for venous thromboembolism and skin problems. The use of multiple invasive devices predisposes the patient to hospital-acquired infections. Sepsis and multiple organ dysfunction syndrome may follow. Adequate nourishment for the critically ill patient is paramount. Other special problems for ICU patients relate to anxiety, pain, impaired communication, sensory perceptual problems, and sleep disorders. First, we have nutrition. Patients often arrive at ICUs with conditions that result in either hypermetabolic states, such as burns and sepsis, or catabolic states, such as acute renal failure. Other times, patients are in severe malnourished states, such as chronic cardiac pulmonary or liver disease. In general, inadequate nutrition is linked to increased mortality and morbidity rates. One contributing factor to underfeeding patients is the frequent interruptions in enteral feedings due to medication administration and multiple tests and procedures. Determining who to feed, what to feed, when to feed, and how to feed are crucial questions that you must ask when caring for a critically ill patient. Collaborate with the physician and the dietitian to determine how best to meet the nutritional needs of the ICU patients. The primary goal of nutritional support is to prevent or correct nutritional deficiencies. This is usually accomplished by the early provision of enteral nutrition or parenteral nutrition. Enteral nutrition preserves the structure and function of the gut mucosa and prevents the movement of gut bacteria across the intestinal wall and into the bloodstream. In addition, early enteral nutrition is associated with fewer complications and shorter hospital stays and is less expensive than parenteral nutrition. Next is anxiety. Anxiety is a common problem for ICU patients. The primary sources of anxiety include the perceived or anticipated threat to physical health, actual loss of control of body functions, and an environment that is foreign. Many patients and caregivers feel uncomfortable in the ICU environment with its complex equipment, high noise and high levels, isolation from family, and intense pace of activity. Pain and sleeplessness enhances anxiety, as do immobilization, loss of control, and impaired communication. To help reduce anxiety, encourage patients and caregivers to express concerns, ask questions, and state their needs. Include the patient and caregiver in all conversations and explain the purpose of equipment and procedures. You should also structure the patient's surrounding environment in a way that decreases anxiety. For example, encourage caregivers to bring photographs and personal items. Judicious use of anti-anxiety drug and complementary therapies such as guided imagery and massage may reduce the stress response that can be triggered by anxiety. Next is pain. The control of pain in the ICU patient is paramount. As many as 70% of ICU patients have moderate to severe unrelieved pain. Inadequate pain control is often linked with agitation and anxiety, and it is known to contribute to the stress response. ICU patients at high risk for pain include patients who have medical conditions that include ischemic, infectious, or inflammatory processes, are immobilized, have invasive monitoring devices, including endotracheal tubes, and require invasive or non-invasive procedures. Next is impaired communication. Inability to communicate is a distressing problem for the patient who may be unable to speak because of the use of sedative and paralyzing drugs or an endotracheal tube. As part of any procedure, you should explain what will happen or is happening to the patient. When the patient cannot speak, you should explore alternative methods of communication, including the use of devices such as picture boards, notepads, magic slates, or computer keyboards. When speaking with the patient, look directly at the patient and use hand gestures when appropriate. For patients who do not speak English, the use of an approved interpreter is required. Nonverbal communication is important. High levels of procedure-related touch and lower levels of comfort-related touch often characterize the ICU environment. Patients have different levels of tolerance for being touched, usually related to cultural background and personal history. It may be appropriate to provide comforting touch with ongoing evaluation of the patient's response. If appropriate, encourage caregivers to touch and talk with the patient even if the patient is unresponsive or comatose. Next is sensory perceptual problems. Acute and reversible sensory perceptual changes are common in ICU patients. The combination of alterations in mentation, such as delusions, short attention span, and loss of recent memory, psychomotor behavior, such as restlessness, lethargy, and sleep-wake cycle, such as daytime sleepiness and nighttime agitation, has been inappropriately labeled ICU psychosis. The patient experiencing these alterations is not psychotic, but is suffering from delirium. It is estimated that the prevalence of delirium in ICU patients is as high as 80%. Demographic factors predisposing the patient to delirium include advanced age, pre-existing cognitive impairment such as dementia, vision or hearing impairments, and a history of drug or alcohol abuse. Environmental factors that can contribute to delirium include sleep deprivation, anxiety, sensory overload, and immobilization. Physical conditions such as hemodynamic instability, hypoxemia, hypercarbia, electrolyte disturbances, and severe infections can precipitate delirium. And lastly, certain drugs, such as sedatives, furosemide, antimicrobials, have been associated with the development of delirium. You need to monitor the patient for delirium and to improve the patient's mental clarity and cooperation with therapy. It is critical that physiologic factors be addressed, such as correction of oxygenation, perfusion, and electrolyte problems. The use of clocks and calendars can help orient the patient. If the patient demonstrates hyperactivity, insomnia, or delusions, management with neuroleptic drugs such as haloperidol can be considered. In addition, the presence of a caregiver may help orient the patient and reduce agitation. Lastly, we have sleep problems. Nearly all ICU patients experience sleep disturbances. Patients may have difficulties falling asleep or have disrupted sleep because of noise, anxiety, pain, frequent monitoring, or treatment procedures. Sleep disturbance is a significant stressor in the ICU, contributing to delirium and possibly affecting recovery. Structure the environment to promote the patient's sleep-wake cycle. Strategies include clustering activities, scheduling rest periods, dimming lights at nighttime, opening curtains during the daytime, obtaining physiologic measurements without disturbing the patient, limiting noise, and providing comfort measures. If necessary, use benzodiazepines and benzodiazepine-like drugs to induce and maintain sleep. Now let's proceed to issues related to caregivers. When someone becomes critically ill, care extends beyond the patient to the patient's caregivers because they are intimately involved. Caregivers play a valuable role in the patient's recovery and are members of the healthcare team. To be effective in caring for their loved one, caregivers need your guidance and support. The experience of having a friend or family member as a patient in the ICU is physically and emotionally difficult, often to the point of exhaustion. Anxiety regarding the patient's condition and prognosis and concerns regarding the patient's pain and other discomforts are some of the issues caregivers confront. In addition, it is common for the caregivers to experience anxiety regarding the financial issues related to the provision of care during the critical illness. Consulting with a social worker is helpful in these instances. Next is caregivers typically experience disruption of their daily routines to support the patient. They may be far from their own home and supportive friends and family members. Ultimately, caregivers of the critically ill are considered in crisis and family-centered care is very essential. To provide family-centered care effectively, you must be skilled in crisis intervention. You should conduct a family assessment and intervene as necessary. Interventions can include active listening, reduction of anxiety, and support of those who become upset or angry. Acknowledge the caregiver's feelings and accept and support their decisions. Consult other healthcare team members such as chaplains, psychologists, patient representatives as necessary to assist caregivers to adjust. The extent to which family-centered care is provided can affect the patient's clinical course in the ICU. Next, the caregiver needs reassurance regarding the way in which the patient's care is managed and decisions are made. Provide the caregiver with the opportunity to participate in decision making. If the patient has an advance directive or a living will, the caregiver will need to see that the patient's wishes are followed. When patients are incapable of making their own healthcare decisions, they may have designated a durable power of attorney for healthcare, and this person should be involved in the patient's plan of care. Invite the caregiver to meet the healthcare team members. Evaluate the appropriateness of including caregivers in multidisciplinary rounds and patient care conferences. It helps caregivers to accept and cope with problems if they observe that the healthcare team is hopeful, caring, and competent. Decisions are deliberate and their input is valued. Next is caregivers of critically ill patients need the convenience of access to the patient. Limiting visitation does not protect the patient from adverse physiologic consequences. Strict visitation policies in ICUs should be reviewed. AACN strongly recommends a move towards less restrictive, individualized visiting policies. This view is gaining momentum in the Philippines, but it is not yet prevalent. This is accomplished by assessing the patient's and caregiver's needs and preferences and incorporating these into the plan of care. The first time that caregivers visit, it is important for you to prepare them for the experience by briefly describing the patient's appearance and physical environment, such as equipment and noise. You should accompany the caregivers as they enter the room and observe the response of both the patient and caregivers. Invite them to participate in the patient's care if they desire. In some ICUs, visitation includes animal-assisted therapy or pet visitation, but this is not very common in the Philippines. The positive benefits of these interventions, such as decreases in blood pressure and anxiety, far outweigh the risk, such as transmission of infection from animal to patient, and they should be a part of the visitation policy. In addition to traditional visiting, research has shown that caregivers of patients undergoing invasive procedures such as central line insertion and cardiopulmonary resuscitation or CPR want the option of being present at the bedside during these events. Even when the outcomes were not favorable, being present helped caregivers remove doubts about the patient's condition, decreased their anxiety and fear, facilitated the need to be together and to support their loved one, and facilitated the grief process when death occurred. AACN encourages critical care nurses to develop policies and procedures that provide for the option of family presence during invasive procedures and CPR. In the Philippines, however, there is still a reluctance to have the family stay in the room when an invasive procedure or CPR is being performed. Now let's discuss culturally competent care. Providing culturally competent care to critically ill patients and caregivers is challenging. Often, meeting the patient's physiologic needs is a priority and overshadows the influence of the patient's culture on the illness experience. It remains important to consider the cultural dimensions of the meaning of sickness and health, pain, dying and death, and grief when caring for critically ill patients and their caregivers. Cultural perspectives on dying and death are complex. Telling some patients that they are dying as a way of letting them prepare for death may be an infringement on the role of families. Others view a discussion about advance directives as a legal device to deny care. Customs surrounding dying and death vary widely. Caregiver requests may range from asking you to leave a window open so the spirit of the dead person can leave, to providing the final bath for the deceased. You must make every attempt to understand and accommodate the family's cultural traditions when caring for the dying patient. Several variables influence the expressions of grief that follow the loss of a loved one. These include the relationship between the grieving person and the deceased, whether the loss is sudden or anticipated, the support systems available to the grieving person, past experiences with loss, and the person's religious and cultural beliefs. It is of utmost importance that you proceed cautiously when approaching patients facing death and their caregivers. Asking patients, "What do you want to know?" and "Who do you want with you?" when discussing options are good starting point. I believe that's the end of our lecture on critical care nursing. Thank you so much for listening and have a nice day.